Kia ora koutou and welcome to Goodfellow podcasts. This episode is kindly supported by the Goodfellow unit. I'm Dr. Louise Kugler, a specialist GP, and today I welcome Dr. Dawn White to discuss the nocebo effect. We will explore how language in healthcare impacts patient outcomes, focusing on the nocebo effect, where words unintentionally harm. Dawn is a GP fellow and GP educator with expertise in supervision, mentoring, palliative care, communication skills, pain and symptom management, and the use of hypnotic language in clinical settings. With over 30 years of experience in general practice, she has served as an examiner and clinical exam case writer for the Royal New Zealand College of General Practitioners and is currently a fellowship assessor. Through her company, mindwave.nz, she provides team training in therapeutic language and supports patients in enhancing their own resources using clinical hypnosis. Dawn is committed to fostering the next generation of GPs, where she emphasises the importance of sustainable and enjoyable career development. Kia ora, Dawn, and welcome to the podcast.
Kia ora, Louise. Thanks for inviting me.
It's lovely to have you here. So tell us, Dawn, what made you become interested in studying how language affects patient care in healthcare settings?
I've always had an interest in communication skills, working in general practice, palliative care, and also as a GP educator. And then I did further training in clinical hypnosis, and that led to a light bulb moment for me. I was introduced to hypnotic language, which is the underlying communication that occurs, whether we realise it or not, with another person's subconscious. And that led me to recognise just how much our words matter, and that the words themselves can lead to better or worse outcomes.
So we're talking about the nocebo effect. So what exactly is this, and how does it differ from the placebo effect?
The nocebo effect, which it means I shall harm, is a reduction in treatment effect or a worsening of symptoms, or an unpleasant response, which is independent from the action of the active treatment. And placebo and nocebo effects, they both represent changes in clinical outcomes due to patient expectations, or what we call subconscious learning, which is produced by the treatment context, rather than what you'd typically consider the active element of an intervention. So that context can include verbal suggestions, patient information, conditioning, so prior experience or the experience of others in a similar situation, media, social, mainstream, and the effects of colonisation in institutionalised racism. So they all contribute to the meaning that the patient makes of any intervention being offered. I mean, the patient in front of you is merely the tip of the iceberg.
So, Dawn, can you share any studies, I'm assuming the nocebo effect has been studied, that illustrate just how important this effect is?
There's increasing amounts of study going on about nocebo. There was a really interesting one where people were rigged up to sham head electrodes and told that there was an electric current going through them, and 2/3 of those people developed headaches. Another study, asthmatic patients inhaling nebulized saline, but told it was an allergen, had measurably increased airways resistance and breathing problems compared to those who weren't told it was an allergen. Another trial of finasteride for benign prostatic hyperplasia, where one group of men were told that sexual dysfunction was a side effect. The other group wasn't given that information, so the group told about the potential side effect had nearly 3 times the proportion of participants who reported erectile dysfunction or related sexual side effects. And in terms of conditioning, we would be familiar with our patients who receive cancer chemotherapy experiencing anticipatory nausea sometimes when they enter the hospital building, sometimes before that. And amazingly, there's also an anaesthetic study that shows that the analgesic effect of a strong opioid can actually be reversed simply by telling people that the infusion has stopped when it wasn't stopped, so their pain got worse despite the infusion continuing. And I've actually got an anecdote from just a few weeks ago. A patient who had been having chemotherapy and had been to see her oncologist, she said to me that the oncologist said they were surprised I haven't yet developed the peripheral neuropathic pain that's a really common side effect. And actually, the very next day, she woke up with those symptoms. And yes, it's a tiny trial, but I had to wonder how much of that was induced by nocebo responses.
So how does the nocebo effect manifest?
Well, there's evidence now that shows that if a health professional mentions potential side effects, patients may be more likely to experience them, even if they wouldn't otherwise have occurred. So this can be really specific. So if you look at trials of tricyclic antidepressants and look at the placebo arms, when you're looking at the placebo arm for tricyclics versus the placebo arm for SSRIs, the placebo arm for tricyclics, people have more dry mouth, more blurred vision, and more constipation, and a higher dropout rate than those in the placebo arm for SSRIs. And that's all down to the expectation and the side effects they were warned about beforehand. And in terms of procedures, so simply telling a patient to expect to feel a bee sting or a sharp scratch before giving a local anaesthetic can cause them to have a higher pain score compared to using positive framing, so calling it a numbing injection or for them to feel more comfortable in a moment.
Gosh, that's a great practice tip. I'm changing what I do tomorrow. How does the brain's neurobiology react to negative expectations or suggestions?
From functional MRI, we know that nocebo effects work via descending modulatory pathways. So, whereas placebo enhances the activity of endogenous opioids, cannabinoids, and the dopaminergic reward system, and it reduces anxiety via the amygdala and its network, nocebo activates things like cholecystokinin and pro-nociceptive pathways and the hippocampus memory networks. So it also activates the hypothalamic pituitary adrenal axis. And that bit is particularly relevant when you consider that there's evidence that this pathway is activated in those exposed to racism. So you could argue that this adds to the reasons why health systems that don't align with an Indigenous worldview and don't involve those groups in ongoing dialogue further disadvantages Indigenous people.
So you mentioned social media and mainstream media before. So are there any influences beyond direct patient interactions that contribute to the nocebo effects?
Yes, when patients have hesitancy with a medication from, say, discussion with a friend or neighbour, someone who's had a negative experience, and it's really hard to undo this, and we have to reboot into a sort of hyper-reassurance mode to make any headway in developing a therapeutic relationship. But studies do show that the empathy and warmth with doing that go a long way to reduce nocebo effects. You mentioned social media, mainstream media. An example of that effect is brand changes. The social media can further amplify inaccurate information regarding a medication. Got even greater power to do damage in Aotearoa, New Zealand, because here we have often a few limited choices for funded brands, don't we? And the additional lack of patient autonomy that this creates further enhances that HPA axis, and it puts people into a state of anxiety and negative expectancy. For instance, when the funded brand Eltroxin was changed to a generic with no change in active ingredients, the rate of reported adverse reactions went up 2,000-fold.
Goodness gracious, yes, that's a significant jump, isn't it? So what about the actions of team members? What effect does the team have on the nocebo effect with our patients?
Well, it really is important that the team is cohesive and the entire team is trained in the use of this language, because it really just only takes one word, one gesture, sometimes just a glance from a team member to completely undermine what was perfectly effective and a really good placebo positive approach. I was present a few weeks ago when a patient was about to have a skin excision. She was very relaxed. She'd had lots before and she knew how to put herself into a very relaxed state. And a well-meaning colleague came up to her and said, "Now, try not to jump too much when I inject the local." And the effect was that the patient actually literally jumped when the needle went in and went, "Ouch!" And all her subconscious heard was the suggestion to jump too much. And I'll come back to sort of negations later.
So thinking about harmful language, why do health professionals often default to language that might unintentionally harm our patients?
Well, I think we all do it just with good intent. We want the best for our patient. We want to warn them. We want to look after them and care for them, but it backfires often. So, for instance, we might like to say sorry as we give an injection or carry out an intervention. And I hear myself doing this still. However, when you apologise, it implies that there is something to apologise for. And therefore, it results in the patient having anticipatory anxiety. They get increasingly vigilant and they create bodily tension, and it brings about a nocebo response. Rather, it might be more effective to invite the patient to imagine going somewhere in their mind where they like to relax and where they feel safe, and ask them just to take us through it and describe it to us. The other strong driver for unhelpful language is that we might feel it's the ethical thing to do in terms of providing informed consent, so listing all possible side effects. So this is just us being truthful about medication we prescribe. However, you could argue that that truth doesn't actually exist until we create it, because the description of side effects or the framing of it like that may create those effects.
So thinking about minimising harmful communication, can you give us some practical strategies or hacks that we could use to reduce the risk of causing harm?
Sure. So using neutral or positive framing. So for procedures, merely saying, I'm starting the procedure now, or I'm giving the numbing medicine now. When you're talking about side effects, you can frame side effect information in terms of the proportion of people who are unlikely to get side effects. One other thing is you can avoid using the word try. So when we use the word try, actually, it pretty much means that we won't complete something, or it invites failure. And there's a reason that a well-known sports brand uses the word do in their marketing rather than the word try. You could avoid using negatives such as don't worry or this won't hurt. This is because the subconscious just hears worry and hurt, and it also means that there might be something to worry about. The subconscious has trouble with negatives. For instance, if I say to you, don't imagine a pink elephant in the room, what are you bringing to mind? And that's where the don't jump too much comes in. So I'm sure we've all come across this with children sitting on parents' lap, relaxed, cooperative with an examination, until the parent says, it won't hurt. And at that point, the child tenses up or moves away. As for the word pain, using comfort scores rather than pain scores. And this has been shown to reduce the need for analgesia. And using a comfort score gives you the same clinical information, but it reframes it in a more comfortable way and helps reduce nocebo.
So Dawn, tell me, can reframing difficult conversations still allow us to be transparent whilst reducing harm?
Absolutely. It's still possible to give informed consent. You just turn it round with the framing that you use. So, for instance, there's been a study that showed that giving flu jabs, if people say that 60% of people will be comfortable and not get a sore arm, rather than 40% of people will get a sore arm, those that were told about the majority that didn't get a sore arm, they would experience less side effects and actually had less time off work in that study.
Oh, that's fascinating. Gosh. Thinking about enhanced communication for healing now, so how can written communication like notes or email play a role in supporting or undermining patient outcomes?
Yes, well, I think we're all familiar with patient portals these days, where patients have full access to notes and reports. When we summarise them, it might be helpful to use positive framing, if possible. So, for example, avoiding words like degeneration, I'd rather put age-related changes. And again, there's evidence that using emotive terms such as disc bulge leads to more second opinions and repeat imaging than using neutral statements like episode of back pain or lumbar sprain. We can also trip up with the language we use in communication. One of my patients received a copy of the letter from her surgeon, coming to me the next week, bringing the letter and saying, the surgeon wrote that I was lying about my symptoms. Obviously, I was surprised to hear this, but when I read the letter, it just quoted the doctor as stating that the patient denies nausea, vomiting, or weight loss. And that's medical language that I'm very familiar with. I'm sure many people are familiar with using that. But the patient had read it as denied, meaning she wasn't telling the truth. And so it actually had destroyed their rapport, and she'd consequently not done anything that the surgeon had said. So just this routine healthcare language can be damaging.
Dawn, I wonder if you could give us some advice to those who think they already communicate well. What would your comment be to that if I said, oh, I already communicate well?
That's great. Well, I think we can all continue to improve all the time. There's always room for some improvement. And if the person wants to invite that, then I would suggest that they record a consultation or reflect on a consultation. It's so easy now with AI. You can get a verbatim written transcript and look at the words you use and just have that nocebo effect in mind. And I think you'll be surprised to notice the subtle adjustments that are possible to make.
Earlier on, Dawn, you mentioned the importance of the entire team being cohesive and patient-centred with their communication strategies. So tell us about team training and why this approach is so essential.
Well, I just think it's so that it doesn't get undermined by one person making a remark. Team training's already been integrated in some countries for years. We all need to be on the same page, and it just only takes one little word to derail an entire encounter.
So thinking as we're coming towards an end of this podcast, if a clinician was to make one change in their communication style today, what would you recommend?
I think the positive framing of side effect information. By emphasize the percentage of people who are free of side effects. And it's using exactly the same information to ensure informed consent, but just transforming the outcome for the better.
Absolutely. So if one of our listeners is interested in learning more about this topic or accessing training resources, where can we direct them?
So I'm happy to respond to any inquiries if people are interested. I'm optimistic it will be integrated into healthcare here in Aotearoa, bearing in mind the potential benefits for patients and the healthcare system as a whole.
Wonderful, thank you. And I suppose being curious about our language would be something else that is important to take away from this podcast.
Oh, yes, certainly. So the more curious we are about our words, it would be great to use the ones that create an opportunity for a positive effect. And that the more curious you become, the more you'll notice. I actually think that GPs and other health professionals will be delighted at how much things can change for the better, improving patient experience. And it might even enhance your enthusiasm for the art of medicine.
Absolutely. Well, thank you so much for joining me today, Dawn. It's been an absolute pleasure talking to you. And if you're a New Zealand GP and would like to claim CPD points for listening to this podcast, our podcasts are eligible, so please log them. You'll also find a list of resources that Dawn and I have used in making this podcast on our website, goodfellowunit.org. If you'd like to get in touch, I'd love to hear from you. Please email me at podcast@goodfellowunit.org. Thank you for listening.